Welcome to another edition of the Rant by Dutch Rojas. Listen, what we want to do is get patients seen as quickly as possible. Did you hear that? We want to get patients seen as quickly as possible. Thank God that everything is not run by politicians and hospital administrators or bankers. One of the things that I'm not liking is all of the stories that I'm seeing about physicians, nurses, nurse practitioners. There's somebody who commented yesterday, why don't you list every single person who works in a hospital? Because we don't have time. We are grateful for every frontline person. In the Marine Corps, we never complained and said, well, you're giving the generals all the accolades. We didn't care because we knew everybody from a private first class to a sergeant was working their rear end off. So this isn't about, sorry, I didn't list your name, sorry, I didn't give you credit, okay? Because we're in kind of a situation, and I'm thankful for everybody that's on the front lines, especially in the big cities, in the urban centers where people are getting smoked. You saw the story last night about Michigan. There are literally dead people in the hallways of Detroit hospitals. Now, sometimes you have to see it with your own eyes, and sometimes you can just believe the source or sources. I think I'll just choose to believe the sources. We continue to see problems with hospitals not having the right amount of equipment. I don't know how hard this is. I don't know how difficult it is, so I don't want to have an opinion about it because I can't understand how we can't get people what they need. That's just absolutely mind-boggling. I mean, we made it to the moon. We've kicked a ton of these disease states in the rear end, and yet we can't find masks, plastic equipment, and coveralls for people. This is absolutely astounding. Now, the other thing that we learned this week is that health systems are trying to keep gag orders in place for social media. So if a physician complains, if a nurse complains about the environment in which they're asked to work, they can be terminated immediately, right? Which means their livelihood. And I would say, okay, take termination, except that all the money that the federal government has promised every citizen in this country, I've yet to hear from one person who's gotten one dime. So that's a complete debacle and failure. This is why we repeatedly say reliance on government and hospital administrators is absolutely futile. Whether you live in New York City or you live in San Francisco or you live in Dallas, Texas, reliance on government is absolutely stupid. These people do not give a rat's rear end about you. You know who cares about you? You and your family. The other takeaway from this week, what are the 3 things we're seeing private practice physicians do that they've never done before en masse? Less than 2% of private practice physicians participate in any kind of bundled program or direct to employer program. If you need me to explain self-funding, direct to employer programs, you're gonna have to watch a different video. Today's not the day. I'm busy smoking a cigar and trying to give people equipment. This has been really, really tough. So, plus we got people walking in the background, which is not normal because usually we're in a studio. Okay, the 3 things. 3, 1, 2, 3. Number 1, if you're a private practice physician and your specialty lies within the elective section of medicine, what you must do post-haste is get your prices. Put them in a bundle, anesthesia, professional fee, implants if it's included, and facility. Add up those 4 numbers, come up with a price. So there's the cost plus margin equals the price. Fairly simple. Many of you call and ask, well, Dutch, what about this and what about that? If you need me to explain basics of accounting to you, I'm certainly happy to do that. There's not many people who can. I'm happy to do it for you. It's really easy to get in touch with us, info@sonosurgery.com. Or you can just LinkedIn message me like everybody else, and I'll make sure it gets to the right person. Now, what's the second thing you can do? The second thing you can do is you can put your pricing into a futures and forward contract format. Futures and forward contracts pay premiums, and they are obligations to do something in the future. What does this mean? Employer A, employer B. Doctor A, surgery center B, radiology center C, all work together and do a direct contract. Now, if a radiology center does business with an employer. Here's how this works. The employer will say, I want to buy from you, Mr. Radiology Center, Mrs. Radiology Center, 550 CTs over the next 2 years. The seller will say, great, we'll sell you 550 CTs over the next 2 years. We'll sign a contract. It's a 2-page agreement with an insurance wrapper around it to make sure that if either side doesn't do what they're supposed to do, that the obligation is still fulfilled. So what this does for doctors is it helps doctors generate future business for a set fee and get paid a little bit of a premium on top of that, and you collect that premium today. Same thing for a forward contract. It is an obligation to do something in the future protected by insurance. Okay, we got that. Number 3, the last thing we need to do is physicians, when you have your pricing, you need to start looking for consumer apps. There are hundreds of literal marketplaces. We're finishing up ours. People are going to want to push a button, geolocate themselves and say, where can I find a colonoscopy? This is very simple stuff. The difficult part is actually the actual contracting. The difficult part is putting the bundles together and having the partners to do it. The difficult part is setting up the financing. We set up the financing, we set up the contracts. So the hard part is building the app, which isn't really that hard. The app also, obviously, any app you choose has to meet the privacy requirements. Generally, I would recommend that you meet the privacy requirements of California and or the EU, because these things are going to come to play in the rest of the 49 states. Everyone is just a little behind California, which I don't generally say, but in this case, it's true. All right, so what are the 3 things? Get your bundle prices ready, get your forward contracts ready, and then get ready to deploy to consumer apps. Listen, if this COVID-19 thing continues for 3 or 4 or 5 more months, most private practices will be absolutely devastated. Oh, look at the one thing that I actually forgot to tell you. Top of mind. Telemedicine is something you guys started using recently. Telemedicine is a hoax. You heard it here. You heard it right here. I don't like telemedicine options. I don't like the AMA. I don't like putting people in a queue. That's, you guys say line. I don't like putting people in a queue to change the position of where people are relative to their physical location. If you, as a physician, can find an asynchronous if you can find an asynchronous app, that's going to work much better. So imagine this. You're one of the world's best doctors, because all of you are, I know it, and you're sitting in front of your regular computer screen, and now you've got 2 or 3 screens. And now people are asking you questions and saying, hey, I'm presenting with this or I'm presenting with that, and you make the determination on who you need to talk to, but otherwise, all the privacy requirements are met and you're literally just chatting back and forth with them on text. So will there be time for pictures? Yes. You can take pictures. Will there be a time for video? Yes. You can do that when appropriate. See the case I'm trying to make here? You are, as a private practice doctor, need to see more patients than you have the physical ability to see if you schedule telemedicine. This will be a big mistake for you, to rely solely on telemedicine while we're going through COVID-19. Asynchronous chat apps, the king of these is Jay Parkinson. You can look him up. He's a doc, John Hopkins guy, super smart, created like a bunch of great businesses, but his claim to fame was building asynchronous chat and really developing that model within the physician-patient relationship. Physicians, if you get an app to do asynchronous chat, you will be able to see 5, 7, 10 patients at once. And then when patients have a question and it's 10 o'clock at night, they can also send it in. You'll have coverage, you'll be able to cover it. This is a consumer-centric play. We are moving away from big hospitals, big physical locations to virtual. you're going to have to pay attention to what's going on in the virtual landscape. So pricing is one section that we talked about. Technology is the next section that we talked about. Make sure that if you don't know anything about virtual, that you start finding people. You can email us, but you start finding people whose business is technology, and they can build these things for you, and your practice can survive. All we want is to survive. That's it. This has been Dutch Rojas with another unedited rant. Dutch out.